So Dr. Hatem Alshora, you met him in the last week with one of his fantastic topics about anesthesia for coronary artery bypass grafting last week. And as a continuation of this lecture series with Dr. Hatem again, it is the second lecture and anesthesia for valvular heart disease. So it's another cardiac anesthesia topic. Dr. Hatem Elshora is a lecturer of anesthesia and intensive care at Tanta University Hospital, and he's currently a locum consultant in anesthesia and intensive care unit in University Hospital of Leicester. He has MD and definitely a Master of Science before that in anesthesia and intensive care, and he has as well European Diploma of Anesthesia and Intensive Care. Dr. Hatem, thanks for coming today, and please go ahead and start sharing your presentation.
Thanks a lot, Dr. Walid. Thanks, Professor Soher. So I have the privilege to be today with Professor Soher. I have been under her supervision through entire my career, being a resident under her supervision until I become a lecturer as well under her supervision. So it's a great privilege to be in the same session with Professor Soher Suleiman. I feel quite lucky today. Today we are going to continue what we started last week about anesthesia for open heart surgery. Last week we spoke about CABG, and today we are speaking about valve heart surgery. So the aim to cover today is the prevalence of the different valve abnormalities, the preoperative evaluation for those patients, as well as our role in the theater. As a rule of thumb, the overall prevalence and severity of valvular heart disease increase with age. And as we can see that all valvular heart disease, the incidence increased significantly with age. If you can see that aortic stenosis increased from 0.02 up to 2.8 just by increasing the age. So this is a sole risk factor. The etiology of the valvular heart disease are quite different depending on the valve affected. Mitral stenosis, rheumatic heart disease account for the majority of the etiology of the mitral stenosis. However, degenerative disease is the main culprit behind the majority of the other valvular diseases, mainly aortic stenosis. The reason it changed according to the country of origin. So in developing countries, rheumatic heart disease is the main culprit. However, in developed countries, aortic stenosis as a result of degenerative changes, as well as mitral regurg, as whether it's a primary or secondary, is the main valvular lesion commonly seen in day in, day out in cardiac surgery. So today we are going to cover these because they are the most common seen, aortic stenosis as well as mitral regurg. Aortic valve stenosis is the commonest indication for valve replacement in the Western world, with an incidence of around 2% in population aged greater than 65 years. Despite the fact that aortic stenosis is a progressive disease that may remain asymptomatic for decades and associated with low mortality, as long as the patients are asymptomatic, aortic stenosis is associated with sudden cardiac arrest of 1%. With the progression of the pathology of the disease, and the patients start to shift from being compensated into uncompensated and start to show symptom and become more symptomatic aortic disease, showing manifestation of chest pain, shortness of breath, syncope, all of these will increase the patient's risk factor and making the patient average survival for 2 years around 50%, and increasing as well the sudden cardiac arrest for those patients from 1% to 50%, and with a monthly incline in the mortality by 2% if left untreated. That's why it's of great importance to have a management for the patient with aortic stenosis. Whether it's aortic valve replacement or going for a TAVI or medical management, this depends on the patient. So what are our goals in the pre-anesthesia evaluation when you are going to see a patient who is scheduled to have an aortic stenosis? There are a couple of questions which we need to have an answer for anytime that you are going to see a patient with aortic stenosis. What is the severity of the valvular heart disease? What is the etiology behind it? Is it a degenerative or this is a rheumatic? Is the patient symptomatic or not? And what is the degree of severity of the symptoms? If there is any symptomatic patient indicate worse outcome? And what are the optimal treatments? Is the patient can be optimized or not? Does the patient show manifestation of heart failure that can be optimized prior to the surgery or not? And what are the patient wishes which come prior to all this? So seeing the patient, you should have a thorough assessment of the patient's history, seeking for question about the patient's symptomatic chest pain, severity of the chest pain, the frequency, the correlation with exercise, whether the patient had any manifestation of syncopal attacks before or not, how is the exercise tolerance of the patient, 6-minute walk test, what is the quality of life of the patient. As we have covered last week, the quality of life gives us a great marker about what are our options. Checking all the patient's laboratory investigation and doing a patient 12-lead ECG to check whether the patient is on sinus rhythm or not, and if there is any other sort of arrhythmias. Echocardiography is a key investigation in the diagnosis as well as the assessment of aortic stenosis. And it's well known that at aortic velocity greater than 4 meters, valve area less than 1 square centimeter, and peak mean gradient of greater than 40 millimeter mercury is an indication of severe aortic stenosis. Despite the fact that echo is the main function of the echo is assessment of the aortic valve, one shouldn't miss the remaining structure which is mentioned in the echocardiography report. Left ventricular dimension and function are considered as a very important indices in the prognosis as well as the survival. As when the disease progress, many patients might start from a very high ejection fraction and then they start dilating the heart and the ejection fraction coming down. So having a dilated heart and low ejection fraction in aortic stenosis is not a very good prognostic indicator. Special care should be given to assessment of the ascending aorta for any post-stenotic dilatation, all other valvular of the heart, mitral valve, tricuspid valve, the other chamber of the heart, such as the left atrium or the right ventricle, in order to assess whether there is a dilatation or dysfunction in case of the right ventricle function, and pulmonary artery pressure if feasible, if the patients have a TR. All of these patients should have, at one point, an angiography as well, or a CT angiography, as we have said last week, in order to assess the severity or any coexistence of coronary artery affection, especially those with chest pain. What are the higher risk patients? So the higher risk patients are patients with low ejection fraction, high New York Heart Association functional status grade 3, grade 4, patients with recent MI or renal failure, and redo patients or patients which are coming in emergency procedure as a result of tight AS and pulmonary edema. And you can see that the volume of procedure performed at the hospital is considered one of the risk factors as well. So being done in a major cardiac center will give you a less risk when comparable to a low volume cardiac center. After having assessed the patients and explained the proposed anesthetic plan, what are the lines and intervention that you are going to do with the patient, and what are the lines that you are going to put to the patient while he's awake and after he's asleep, obtaining an informed consent for all your anesthetic care, and answering all the questions. I find this very important in alleviating the anxiety and tension which is associated with having a cardiac surgery. For cardiac anesthetist, this is our job which we do day in and day out. For all the patients, this is a totally vague experience that they are going in. So explaining all the steps, the timeline that they are expecting, and what are their journey since you will meet them in the anesthetic room till they are discharged from the hospital, is quite easily alleviate the anxiety rather than going for a medical management. So, intraoperatively. Last week, we spoke about the intraoperative monitoring. What are the basic monitoring which should be done for any cardiac surgery, variable from the AGABI, protocol for the monitoring, the TOE, and the neurological and hematological and coagulation monitoring. And the main aim for the induction is to do a balanced anesthesia in order to send the patient sleep and alleviate the pressure response with the intubation and maintain the hemodynamical goals with aortic stenosis. As we said last week, it is not about a single medication that you're going to give to the patient to send them sleep and keep them hemodynamically stable. It's a combination of the medication that you can reach and titrate till you're safely reaching your goals. So what are our intraoperative hemodynamic management for the patient with AS? We all read this table at one point or another in our career. So it's quite important to keep the patient in a sinus rhythm, as most of these patients have a tight or a fixed cardiac output. In order to maintain their cardiac output, keep the patient in sinus, they can't afford losing their atrial kick. And if the patient develops an atrial fibrillation or SVT, aggressive management should be done in order to manage this. Keep the patient with a normal heart rate. Avoid excessive tachycardia by giving short-acting beta blockers, or severe bradycardia by giving glycopyrrolate if appropriate, or lightened anesthesia, depending on what is the leading cause. All the patients with AS are depending on their peripheral vascular resistance in order to maintain a good perfusion pressure and a good coronary perfusion pressure. Suspecting these patients to hypertension and the vasodilatation will lead to inefficient coronary perfusion, and these patients might have an intraoperative ischemia. Therefore, it's quite important to maintain a normal blood pressure, and if needed, an alpha agonist like a phenylephrine can be used. Maintain the preload without being on the two scales of the spectrum, keeping the patient appropriately loaded, and avoid myocardial suppression. Does the echo have a role in assessment of the aortic stenosis? Definitely. Transophageal echo has been recommended by the American Society of Echocardiography as a key point in their assessment, and these should be used and considered in any patient going for a valvular heart disease. So what you are expecting to do when you are anesthetizing a patient with an aortic stenosis? The first step, I believe, is the assessment of the valve morphology. Whether the valve is a bicuspid valve, only two leaflet, or a tricuspid valve, or very rarely, it can be a quadricuspid valve. The other thing, other than the morphology, is what is the degree of the motility? Is the valve open very well, as in here, or there is a limited motility? The degree of calcification and degeneration which appear in the valve. All of this will give you an idea about the severity of the aortic stenosis. Do a 2D measurement for the left ventricle outflow tract, as well as the sinutubular junction and the sinus of Valsalva. All of these measurements will be helpful, either for calculation of the aortic valve area if you are doing continuity equation, or helping the surgeon in predicting what are the size of the valve that he is going to be used. So it's quite a common question when you're doing an AS patient that the surgeon will be asking, what is the annular diameter, in order for them to have an idea what they are going to do, or whether the patient will need another procedure in addition to augment their sinus. As we said about the continuity equation, is one of the technique which is used to assess the aortic valve area. So doing a pulsed wave at the LVOT, as well as a continuous wave in here at the aortic valve, and this will give us an aortic estimation of the aortic valve area. The only downside of doing the continuity equation, it is derived technique. So it's totally dependent on your measurement. If there is any fallacies in the measurement of the LVOT, or your Doppler flow is not parallel to the direction of the flow, all of this will increase the fallacies. You have to always be aware that our max pressure gradient and mean pressure gradients will be less than the one measured by the cardiologist when the patient was awake, because this is a totally different situation that we are in. It's a different loading condition. Most of the patients are fasting for long hours, so their preload is different. The patients are under GA with myocardial suppression, so you have a totally different. This doesn't indicate that this patient is not severe enough. That's why you have to get all the parts of the puzzle, the morphology of the valve, the aortic valve area by continuation, as well as the mean and the max. As we said, any velocity greater than 4 meters should be considered as severe. So if you have a patient with a velocity of around 5.5 meters, this is definitely a severe. And this is just a reminder again about the criteria of severe aortic stenosis. It is not uncommon to find many patients who are having aortic stenosis having a regurg as well. That's why it's very important to assess the severity of the regurg in all patients having a surgery for aortic stenosis. So assessment whether the regurg is central regurg or eccentric regurg will be helpful in the assessment of what is the cause and what is the etiology behind it. So in many cases, which having dilatation of the ascending aorta or the sinus of Valsalva, is just a dilatation of the annulus of the ascending aorta and the aortic valve, which will lead to loss of the coaptation between the cusp and leading to a central regurg. But if there is a prolapse of the aortic valve, or even if there is a perforation in the leaflet, there might be an eccentric jet like the one below. assessment of severity, there are lots of methods which is used to assess the severity of the aortic regurg. Of the narrowest point at which the flow deflects from the aorta into the LVOT. And if it's less than 0.3, this is considered mild. From 0.3 to 0.6 is considered moderate. And if it's higher than 0.7, is considered severe. Doing a pressure half time as well in transgastric views can be very beneficial in a quantification of the amount of the regurg. The rule of thumb is if the pressure half time less than 200 milliseconds, this is a severe regurg. And if it's greater than 5 milliseconds like this one, this is just a mild regurg. And one of the other simple techniques that you can use for assessment and quantification of the aortic regurg is doing a pulsed wave Doppler in the descending aorta. So this is descending aorta. We are doing a pulsed wave Doppler in here. And we can see that there's only one way flow in here. There is no reversal of the flow, if compared to this one, which have a definite reversal in the flow, indicating severe aortic stenosis. You can tell by now that in echocardiography, it is not by a single parameter. We try to collect parts of the puzzle from different views and from different parts, so that when we are saying that this is severe, we are 100% sure. The mechanism of aortic regurgitation, as we said, can be just dilatation of the whole ascending aorta as well as ascending aortic root, or just dilatation of the root, or all of these will lead to a central regurg. Sometimes patients can have an infective endocarditis leading to a perforation in one of the cusp, or the patient can have a flail leaflet, which will lead to eccentric jet. And in some occasion, because of the calcification or rheumatic fever, there might be a restriction of the cusp movement in there. After assessing the left aortic valve and determining the severity of the aortic stenosis, any concomitant aortic regurg, we should be following what is the assessment of the left ventricle. How is the left ventricle is doing? The right ventricle, we can eyeball it and say that the contractility of the left ventricle in here is symmetrical. I can tell that all the walls are moving. There is no regional motion abnormality. The whole of the heart is moving well. It's almost kissing papillary muscle. So I can comment on the left ventricle function as well as the volume status of the patient. Assessment of the longitudinal function of the right ventricle as well as the diameter is of great importance. But it is not all about eyeballing, so you must have some quantification as well for the ejection fraction. So M mode is an estimation of the ejection fraction. The downside of doing the M modes is it's just assess the movement of those two walls. However, if these two walls are affected and the remaining of the heart is contracting very well and hyper estimating for that, this still might be the patient having a low ejection fraction or a mild ejection fraction in here, and vice versa. So using another technique to confirm what is the ejection fraction is a multiplane, what's called as a sensor method. And the 3D doing the assessment for the ejection fraction consider coming off the old drawbacks which is associated with the previous two methods if done correctly. Most of the patients with aortic stenosis can have an LVH, and the rule of thumb is if the walls of the ventricle, left ventricle during diastole is greater than 1.2, this patient have some sort of LVH. And the importance of LVH is the greater the LVH, the greater the oxygen demands requested by the heart, and these patients will be risky during submitting them cardioplegia as well as the increase the anginal load. Diastolic dysfunction. Speaking about LVH, LVH will impair the relaxation of the heart. Therefore, assessment of diastolic dysfunction should be an integral part of any echocardiography assessment done for all the patients. As we all know that there are lots of parameters which are done for diastolic dysfunction. The simplest one among them is the EA ratio. Usually, the EA ratio is 1.2, 1.4, because the passive parts of the left atrium filling to left ventricle contribute the majority. Once the ventricle starts to be impaired relaxation, left ventricle and diastolic pressure will be higher, leading to reduction in the contribution, the passive part, and more volume will be coming in atrial kick, leading to grade 1 diastolic dysfunction. With more persistent increase in left atrial pressure will increase, leading to pseudo normalization in here. And we can see that the E wave is greater than the A. But if you follow it for a couple of waves, which are associated with different respiratory cycle, you can see it in here, E and A are nearly equal, And here, even the A are exceeding the E, which indicating that this is a pseudo-normal wave rather than it's a normal EA ratio, indicating grade 2 relaxation failure. And in cases of prolonged aortic stenosis or prolonged increase in left ventricle end diastolic pressure, there might be a restrictive pattern, which in the EA is greater than 2, and we can see it in here. Once you have assessed the left ventricle of the heart systolically and diastolically, it's important to assess the other chambers of the heart, the left atrium, because dilatation of the left atrium is indicative of a long-standing disease for a long time. And many patients with higher left atrial pressure can be associated with increase in the pulmonary venous pressure and pulmonary hypertension on the long term. Assessment of the mitral valve, both in 2D as well as in Doppler, will give us an idea whether this patient have a concomitant lesion on other valve or this patient is just an isolated aortic valve disease. As we can see here, this is a marked dilatation in the left atrium, 5.5, which is indicating a long-standing calcification and aortic stenosis. Diameter of the right ventricle are very important as well. So doing assessment of the tricuspid annulus, the right ventricle first diameter and second diameter can give us a rough idea about whether there is a subjected increase in the afterload in front of the right ventricle, and whether together with the systolic function of the right ventricle longitudinally and radially will give us an idea about how the right side of the heart is doing. We shouldn't miss about the ascending aorta. So ascending aorta should be assessed for all patients, including the patient for AS. As we can see here, this is a patient who have a dilated ascending aorta, 5 centimeter, and this patient can be attributed to dissecting later on. So this should be attributed during the same session. Again, you shouldn't do the measurements in only one view, so you have to do it in long axis as well as in short axis to make sure that this patient is severely dilated, and this patient had an aortoplasty in addition to his aortic valve replacement. Caring for any shunts inside the heart. So this is a patient who had a patent foramen ovale. This is the left atrium, right atrium, and you can clearly see that there is a flow which is passing from here to there. Once you have done the echocardiography for all the patients, then preparation for cardiopulmonary bypass. And as we said last week about antifibrinolytics and whether to start the patients on tranexamic acid or aprocitentan depending on the institutional protocol, and depending on the patient's own risk, whether there is a higher risk for the patient to bleed, we are starting them on a higher protocol of antifibrinolytic. And before going to bypass, all the patients should be having heparin between 300 to 400 international unit per kg, aiming for an ACT between 400 to 480, depending on the department. Care must be taken that cardioplegia can be challenging for patients with LVH, whereas these patients will require higher dose of cardioplegia. And in many occasions, as we say, that it can be accompanied by aortic valve regurg and or coexisting coronary artery disease. Therefore, a direct ostial installation of the cardioplegia or retrograde plegia might be beneficial in those patients. And if retrograde plegia is considered, then care with transesophageal echo should be given in order to guide the surgeon to insert their cannula inside the coronary sinus, because sometimes it's quite tricky. Last week, we spoke about the checklist for weaning off cardiopulmonary bypass. And as we said that we are going to speak about it slightly in more details today. So in 2012, in Cardiac Annals, there was a clinical review about the management of weaning of cardiopulmonary bypass of cardiac surgery, which I strongly recommend for anyone interested in cardiac surgery. And they were saying about after checklist has been made, patient is normothermic, electrolyte is normal, the surgeon have removed the cross clamp and the heart is properly de-aired, there is no air inside the heart, and restart the ventilation again, then there are hemodynamic targets which you should be seeking for. So giving the patient into a normal heart rate between 70 to 90, probably 100. If the patient is bradycardic, then we can consider pacing the heart. It's quite important to do a sequential pacing for most of these patients to keep the atrial kick, and all patients must have some sort of ventricular backup to protect them against heart block later on. All the patients should be optimized regarding the preload and try to maintain a decent MAB around 70 to 80 millimeter mercury. Once all of this is done, trial weaning cardiopulmonary bypass in a stepwise approach should be okay. Majority of patients with aortic stenosis should be weaned from cardiopulmonary bypass uneventfully. However, there are some patients which might be tricky coming off bypass. And the reason will be one among all these four. It is either surgical or technical fault as a result of a valvular regurgitation which hasn't been met, as the patients have another valve which is diseased and it is not addressed at the same session. So coming off bypass after doing an AS and the patient have an MR, this might be tricky and the patient might fail from weaning for cardiopulmonary bypass. Or the patients have an intracardiac shunt which was not closed at that time. And this can be picked up easily when we're coming off the bypass by doing a transvaginal echo. Ventricular dysfunction, by assessing the contractility of the heart as we have done, any residual motion abnormality. This can be either as a result of failed de-airing of the heart. We haven't de-aired the heart properly, so air embolism into the right coronary led to a residual motion abnormality, or even some complication can take place like a stitch in the CX artery can lead to a residual motion abnormality, and this thing has to be ruled out before try weaning off cardiopulmonary bypass for the second time. And highly suggested will be assessing the residual motion abnormality to the feeding area of the CX. And this again can be picked with transvaginal echo. Vasoplegia is the third common cause, causing failed weaning cardiopulmonary bypass. And by doing a transvaginal echo, we will see that the heart is hyperdynamic. Despite of that, the cardiac output is high, but the mean arterial pressure is low. And we spoke about that there are many patients which might be in a higher risk, like the patient on ACE inhibitors, or patient with low ejection fraction, or the patient have been on cardiopulmonary bypass for a long time. And these patients might need an optimization of their vasopressors before trying weaning off. And again, this can be picked up by transvaginal echo. The last cause which can take place is left ventricle outflow tract obstruction. So left ventricle outflow tract obstruction, or SAM, systolic anterior motion excursion of the mitral valve, can take place in many occasions. Initially, if the patients have HUCM or hypertrophic obstructive cardiomyopathy, or if the patient have a mitral valve repair. And in any of these, with a high velocity, this will suck the anterior mitral leaflet toward the LVOT, leading to a dynamic obstruction of the flow. And again, this can be picked. If this is the case, then reducing the inotropic support, giving the patients fluids might be the best option for those patients, or even giving the patient some beta blockers to reduce the contractility. So after doing a full echo assessment for the patient, we come with either one of two conclusions. It's either a surgical or technical fault, or there is something need to be addressed, a ventricular failure, which in this case, inotrope, plus or minus vasopressor, if we decided to go for inodilator, will be a drug of choice. Or on the other side will be a vasoplegia, and the vasopressor will be drugs of choice. If all of this have failed, then a mechanical circulatory support should be sought as early as we can to try to protect the heart from further injury. The mechanical circulatory support depends on the availability in your unit. So in our unit, the intra-aortic balloon is the primary mechanical circulatory support which is used, and in highly selected cases, a VA ECMO can be considered for a highly selected group of patients. Inotropic support predicting after cardiopulmonary bypass. So there are some predictors which will tell you whether you will need inotropes or not. Because we said last week we should have a plan regarding the patient, what inotropes are coming off with or not. So if you have a patient with a wall motion abnormality and poor ejection fraction, combined or complex surgery, having a mitral valve or CPG plus the aortic valve, and the surgeon is using a long time on the bypass and aortic cross clamp, then these patients almost always will need inotropic support coming off bypass. It's quite important, as we say, to have some sort of ventricular pacing. It's beneficial if it's a sequential atrial and ventricular pacing to maintain the atrial contribution in the cardiac output, but it's always having a ventricular pacing. So doing a VVI or DVD coming off bypass is important to reduce the risk of immediate and delayed complete heart block. The immediate postoperative complication can be variable between bleeding, especially if immediately after the operation, the patient started to wake up, the pressure started to increase 180, 190, and this will produce pressure on the suture line in the aorta, leading to a massive bleed. So special care should be done for the pressure management, keeping the patient normal, tensive as much as we can in order to avoid any tension in the suture line. Tamponade, as can be suspected by chest X-ray and confirmed by echocardiography, is another thing, which should be suspected clinically if the patient developed low cardiac outputs immediately after surgery and having high filling pressure. And finally, arrhythmia. All types of arrhythmia can take place after surgery, especially third-degree heart block with high prevalence of these patients might need a permanent pacemaker later on. Air embolism, despite the fact that most of the patients can develop air embolus immediately coming off bypass, but some patients might have pockets in the left atrial appendage or in the left ventricle. And if the patient is not de-aired appropriately, then it can occur delayed after transferring the patient into the ITU. And the high suspicion should be if the patient developed a right ventricular failure or arrhythmia, which was not there on the last echo done in the theater. Anesthesia for mitral valve surgery. Mitral stenosis is the most common lesion which we found in our countries. And most
Hatem, may I stop you here for just a couple of minutes if you wish?
Yeah.
I'll just add the evaluation of the first lecture. So this is a kind of assessment for documentation of attendance. So it's a couple of minutes. Sorry for interruption. I just feel you need a cup of water or a glass of water, and you need to swallow for a minute the aortic, and then before we switch to the mitral. So this is an assessment for the first lecture. Definitely the second lecture is not finished yet, so please, we have 51%. I leave that for a minute or two. We usually get 70% of attendees document their presence here in the first minute. Sorry, Dr. Hatem, to interrupt you. I feel that they needed a break. Is this documentation attendance blocking your screen, Dr. Hatem?
For now, because I can take it down.
If you can take it aside. Can you take it aside and you continue your lecture?
So it's done?
Okay, perfect. So please go ahead. I'll leave it for a few seconds more.
Okay. So if we're continuing with the mitral stenosis, it shouldn't be long from now, so it should be the easy part. Mitral stenosis, as I said, it's the most common which is occurring in developing countries, and it's defined as a valve area less than 2, and if it's less than 1, it's a critical or severe stenosis. And the etiology, as we can see in the first slide, if you can remember, is rheumatic fever is the most common contributor or culprit behind the mitral stenosis. Degenerative can still be a cause, but rheumatic fever is the most common. So what's happened with those patients? Most of those patients is failing from failing the heart from left atrium to left ventricle, leading to increased left atrial pressure. And with persistently, these patients will have a dilated left atrium, causing many patients an AF for some sort of arrhythmia. And associatedly, there might be a pulmonary venous pressure as well, can be increasing, leading to pulmonary hypertension. And in the long term, there might be a pulmonary hypertension as well, and right ventricular failure. So again, same question has to be answered. What is the severity? What's the etiology? And what we're going to do with those patients? Our goals will be exactly the same, keeping them sinus. If they are still in sinus, keep the heart rate with a normal, maintain the afterloads for those patients, they are fixed outputs, and try to maintain the contractility. And for the assessment in theater, the severity of the mitral valve depends on the valve area. So valve area less than 1, with a mean pressure gradient greater than 10, considered severe stenotic. And as we can tell that by the morphology, having a hockey stick appearance of the left of the mitral valve can indicate of the rheumatic fever. And you can really tell that this, if this is a motion, this is obviously a picture, but if in the movie, it was not clearly moving well and there is not opening well. Assessment of the mean pressure gradients is quite important as well. So in the normal heart, you have a mean pressure gradient of around 1 across the mitral inflow. And in severe stenotic, you can find it's increased up to 12, the mean, which indicating severe stenotic disease. And one of the simplest methods to assess the severity is the pulmonary vein flow. So this is a normal pulmonary vein flow, S wave and D wave, and finally the atrial kick. Having a reversal of this wave, the reversal of the S wave is an indication, almost always indication of severity of mitral stenosis. Never forget to assess the left atrial appendage for all of those patients. So doing this in X-plane in order to make sure that there is no thrombus, and doing a pulsed wave as well is an indicative. Not to miss this. So finding a smoky heart inside the left atrium is quite suspicious for having a thrombus, because this indicate a stasis inside the left atrium. Mitral regurg can be a primary if there is a lesion inside the mitral leaflets, like myxomatous degeneration or rheumatic disease or endocarditis affecting the valve, or a secondary, whether it is ischemic, which can cause tethering of the chordae, which will lead to inappropriate closure of the valve or the leaflets of the mitral valve, or even a dilatation of the heart as occurs with non-ischemic cardiomyopathy. Many of these patients can be left asymptomatic for a long time until they are either picked up with someone auscultating the heart, finding a pansystolic murmur, or developing AF, or even developing manifestation of heart failure. The major concern in these patients, despite being asymptomatic, that the risk of sudden cardiac arrest is significant, and it represents 2% of the total cardiac arrest among medical patients, as well as the risk of irreversible LV dysfunction. Most of these patients, as the disease progresses in the left ventricle, and despite the fact that the ejection fraction initially seems to be falsely normal, their actual contribution of the left ventricle is very low because the heart starts to vent toward the low pressure left atrium rather than going forward toward the water. So our option is either going to repair or replacement. Usually, the rule of thumb, if it's a mixed lesion, stenotic and regurging, going for a replacement. If it's a single leaflet or it's just a prolapse of a leaflet or a rupture chordae, so it's a correctable condition, we can go for a repair. So why to bother and do a mitral valve repair? Mitral valve repair, there is avoidance of long-term anticoagulants, preservation of continuity of the mitral annulus, which will maintain the geometry of the left ventricle and systolic function as well. And in here, we are trying to maintain the hemodynamic goals in order to reduce the regurgitation fraction by keeping the patient slightly on the tachycardic side and reducing the afterload, because any increase in the afterload will just increase the regurgitation fraction to the left atrium, adequate preloads, and avoid the regurgitation. These are the quantification for the mitral valve regurg. 3D echo can have a very important role in assessing the mitral valve. It can tell you whether there is a coarctation gap or there is a significant lesion which can take place. And in here you can see that there is a definite cleft between the B3 and the B2, and a bit of prolapse here in the A2 as well. And finally, transvagal echo is very important even after the repair, because you will do the assessments of the patient. So coming off having this picture of severe regurg after the repair is not a good thing, and this patient will be struggling. So this patient had to go again in order to do a replacement this time rather than a repair. Finally, anesthesia for valvular heart disease can be challenging, but doing transvagal echo, you can really do a change for the patients, and you can make a change regarding the choice and the decision which are going to be made for the patient. Thank you.
Thanks very much, Dr. Hatem, for this, again, comprehensive and nice, easy way of presenting valvular heart disease, and squeeze it and compress it in just one lecture is a kind of a challenge on its own. So thanks very much for your all efforts here. And my apologies for the interruption in the middle of the lecture. I felt that everybody needs a break to separate between mitral and aortic. It's two different topics. I kindly start to put your questions in Q&A section. Avoid putting that in the chat. And I'm starting with a couple of questions I have here. The first question from Muhammad Mutwalli: does the fraction of shortening has any role in assessment of LV function, particularly in left ventricular hypertrophy?
Okay, so fraction shortening and ejection fraction are interchangeable, and there are some equations which can change from fraction shortening to ejection fraction. So does it have a role? Yes, it has a role, as ejection fraction has a role. If the patients have a decent ejection fraction in those patients, this should have a higher or lower risk of morbidity and mortality, and the same. So it's contributed exactly the same with the patient ejection fraction.
Okay, so second question is from Muhammad Khattab. Is there an optimum blood pressure post-aortic or mitral valve replacement or repair? And which is better to use, nitroglycerin or any other hypotensive drugs? May you allow me, Dr. Hatem, to say my experience here in Ireland, and then you say what do you do in UK, so we can change our experiences. Nitroglycerin is a drug of choice in our unit, but not to lower the blood pressure. It's used mainly in coronary artery bypass grafting as to make coronary arteries dilate. They can use labetalol or nitroglycerin. There's no preference in our center. The blood pressure is usually kept systolic around 100 most of the time after any valvular heart disease or coronary artery bypass grafting. I don't know what's your experience.
So from our point of view, using GTM, yes, we can use nitroglycerin or GTM for blood pressure management. What is our aim for those patients? Our aim is to keep a MAP of around 60 to 65 for the majority of the patients. If the patient is chronic hypertensive or the patients have some sort of renal impairment and the patient is developing CKD, then we can seek for a higher MAP, 70 or 75. Patient with right ventricular failure or patient coming off with a right ventricular impairment, we sometimes will keep them on higher MAP as well, 75. This is our criteria, our goals.